So we've done a lot of research on what treatments we should be using, but we've done very little research or assessment of the services within which those treatments are provided. Back in 2012 we started the UK National Audit of Seizure Management in hospitals, and the results of that were a really big surprise for me, because I'd spent most of my career up to that point running randomized controlled trials and other studies to try and work out what treatments we should be using. And what we learned actually was that the way that healthcare is coordinated leaves a lot to be desired. So what we find is that there are a large number of people with active epilepsy that aren't actually in neurology care, and they present to the emergency department, sometimes multiple times. They never get to see somebody with epilepsy expertise, and they don't get put on a pathway to see somebody with expertise. So we learned that for people with first seizures, about half of them get through to see a neurologist, and for people with active epilepsy, less than half of them get put on a pathway to see a neurologist. And if they don't get to see somebody with the expertise, then how are we going to do something about preventing them to get into hospital? What we also found is that their assessments in the emergency department were often inadequate, or they may have had investigations that they don't need. So a large number of people, for example, with active epilepsy end up getting a CT scan of their head, which is completely unnecessary for the great majority, represents an inappropriate use of health service resources, and is exposing people to unnecessary radiation. So one approach to getting information is running an audit, and that's quite labour intensive because it usually requires individuals to record additional data, and you can do that efficiently via websites, but it still involves people collecting additional information. But increasingly hospital systems are collecting data routinely, administrative data, and those data can be used to assess how systems are performing. So again, in the UK, we can use something called hospital episode statistics data, and analyses of those data reinforce what we found in the NASH audit, in that a significant proportion of people don't get through to neurology after attending the emergency department. And if you're not already in the system, your chance of getting into the system is really low. And we also see that there's ageism in the system. So if you're elderly, you're much less likely, for example, to be referred on to a neurologist. So if we're going to improve care, we need to get neurologists and neurological expertise at the point where care is needed. And that could involve having neurologists or nurses with specialist expertise being available, particularly when patients are admitted or attend emergency departments. But we also need pathways of care which make it easy for those working in emergency departments to refer people on to neurology and seizure services, but those services also need to be responsive to the needs of people. And historically, epilepsy services have focused very much on the complex care and the needs of those with refractory epilepsy, focusing on very high-tech solutions, when in fact our opportunity to improve the quality of life for people with epilepsy is almost certainly to get the simple things right, which means having people with the skills in the right place, dealing with the people with the need. Yeah, so there are lots of barriers. One is lack of people in the system, which is certainly the case for places like the UK, Ireland, and many European countries where we don't have enough neurologists or people with neurological expertise to see the patients. So the European Brain Council funded a piece of work called Value of Treatments, and for epilepsy we decided to focus on what would happen if we provided better care. And we have guidance from institutions like NICE to tell us what care should look like. So in that piece of work we didn't seek for perfection, we just looked at what would happen if we produced what NICE suggest and compared that with what's being done at the moment. And what you find is that actually we're wasting money at the moment, and if we provide better care, we can actually save money.